Now, Dr. Praveen Rajesh has been conferred with a diploma of membership in endodontics from the Royal College of Edinburgh in 2019. And it's indeed a very proud moment for me to tell that he is the first endodontist residing in India to receive this degree. He completed his MDS and BDS from Rajiv Gandhi University of Health Sciences, Karnataka in 2014 and 2010 respectively. He is a passionate endodontist who loves to practice and preach evidence-based endodontics. He has special interest in separated file retrieval and dental photography. His new patent allows manufacturing of an indigenous broken instrument retrieval device. His work on instrument retrieval was published on the cover page of JOE. That's another feather in the cap. He has numerous publications and has authored chapters in books. He has been conferred with the Clinical Excellence Award by IACDE in 2019 and 21, and a Specialist Dentist of the Year Endodontist FAMDent Award of Excellence in the Dentistry in the year 2018 and then again 2021. So let's welcome this energetic and vibrant young endodontist. Over to you, Dr. Rajesh.
Thank you, Kanwalpreet ma'am. That was so sweet of you. And thank you, Mahalakshmi ma'am and Rajkumar sir, for this wonderful opportunity. I kind of felt out of place because I'm probably more of a clinician than an academician. But Rajkumar sir and you have been so kind enough to guide me on what you exactly require from the presentation. So I hope I can do justice to your time. So I'll just share my screen. Okay, I hope the screen is clearly.
It is.
Yeah. Okay, ma'am. Okay, so today our topic is documentation and endodontics. So documentation simply means creating and maintenance of records. It sounds quite simple. And second, sorry, I have some problem with my slide. Yeah, it sounds quite simple, just maintaining records that you do every of the cases that you do every day. However, in India, they found that a staggeringly low number of dentists, just 22 to 38% of them, actually document their work. This is according to a couple of questionnaire studies conducted in India. Well, we have a lot of things to blame. However, I find that the predominant reason why people don't document in regular clinical practice is because there are no consequences. Abroad, where there's insurance drive and there is a lot of litigation going on if you don't prove yourself right. These consequences drive the dentists to document each and everything they do. So the level of documentation outside our country in our developed compatriots are much higher. So in our practice here in Chennai and Bangalore, we document as much as we can. And this is a discipline and it's a habit that we cultivated through my journey. So I just want to briefly take you through my journey just to show you why documentation became so important to me. So in 2014, 11 to 14, when I did my MDS at Bapuji, all my faculty used to push us to document. We never liked it. We like to do a lot of cases. We like to, experience that, variety of cases, but we never knew that documentation was so important. So we always, had an aversion towards it. And we thought this is the most difficult phase, let's finish MDS and then, let's rock the world. Let's do big things. So in 2014, I joined as senior lecturer. And I soon realized that the paycheck that I received was not even enough for my day-to-day needs. So I had to do on-call consultation like most of us did during the early days. And I faced the same challenges that most of us faced during our early days. Very difficult, complex root canals. The GP expects us to solve these kind of cases. God knows how. Then I soon realized in a year's time that this is not what I want to do. This is not my style of practice. I want to do something better. I want to do something that is, that justifies my heart. So I changed my institute. I went to Pondicherry and started training under the microscope, joined as senior lecturer at IGIDS. And one of the main reasons why I shifted was I wanted to document a lot of cases, because an exam that I was planning to give at that point of time required me to submit 4 cases, 2 endo and 2 restorative cases. And I started preparation for that exam, which is called the Endo. And over a period of time, I developed a lot of interest in instrument retrieval as well. So in 2018, I retrieved a lot of files and I was able to document them quite well. And I received the Endo degree as well in that year. And after I felt that I achieved this, I felt, let's open up a practice where we focus a lot on complex endodontic work, which I was scared of in 2014-15. I thought we should open a practice where we do predominantly complex endo work. So in 2019, we opened a practice where we try to focus a lot on referral endodontics. And in 2022, we opened a branch in Bangalore where it's exclusively referral endodontics. So throughout this journey, I realized that I kind of almost wasted first 4 years of my life trying to do consultations. I realized that, referral practice is way more rewarding for an endodontist. And as a teacher, I think it's our duty to teach our students that, which pathway to take, referral or consultations. And I think it's our duty to let them know the truth. And another important goal that I have is I want to increase the GPs and patients' trust in endodontics, because over a period of time, we've seen the dominance of implants go up so much that every time I give a lecture on retreatment, there'll be one person in the audience say, why don't you extract that and put an implant? That makes me kind of cringe. So I want that trust back in endodontics. And another reason why I chose this path was because a teacher of mine who I value a lot, she once told a medical faculty that, endodontics is a part of general dentistry. It's not really a specialty, it's just a part of general dentistry. You could call ortho or surgery as an actual specialty. Now that hurt me a lot, because I felt, we do 3 years of MBS because we want to specialize in something. So in fact, a lot of my batchmates as well, they finished MBS and they did an implant course and they do other courses. So I realized that to achieve all these goals, the only way is to do a referral practice. So that's what we've been doing since over the last 3 years, and it's been going on quite well. We've been able to treat several complex endo cases. Now, although I'm satisfied with my work, I know there's a lot of hard work involved in treating cases like these. Our patients, even sometimes our colleagues don't appreciate it, because it's happening somewhere inside the tooth. It's not seen out. Patients definitely won't recognize it. So how do you make them recognize it? Well, show them photos. So that's the reason I started, improving my photography skills. It's very easy. If I can learn photography, I think everyone can. So we started recording photos, and we found that it literally changes the way you communicate with patients. In fact, it improves your treatment presentation skills. According to Jim Philpower, he's one of the practice management consultants in the US. He says that if your practice doesn't convert at least 80% of the patients, you're not doing well. And they found that if you, they found that in a survey, most of the dentists were not achieving 80%, but then when they added one small component, that is when they presented their cases with photos, this literally, changed. So photographs are very important, especially the posterior photos where the patient can't see what's going on. Even for a simple class one, if you want to convince a patient, if you want them to go for the right treatment, you need to show them. This was a case. So these are all some real life examples, which made me an even more stronger believer of documentation. So this was a class 2 old filling which was broken, and the patient said he just paid like $1,000 before why should I spend a bomb on this doing an inlay or an onlay? Then we had to excavate everything, take photos, show him our case album, and then explain to him, this involves line angles, it involves functional cusps. So we were able to enlighten the patient and do the work. There are a lot of cases where the treatment plan may be right, but then the explanation to the patient may not satisfy the patient. So we had a case where there was a fractured, this is a typical cracked tooth syndrome, right? There's a, partial crack there, which was causing irreversible pulpitis to the patient, but patient was not given proper explanation. After going to around 3 to 4 different clinics, he came to us and we were able to give him the right explanation, and then we went ahead with the treatment. Certain cases where they want us to do a particular procedure, like this case, they wanted us to do the re-root canal and save the tooth. We had to explain the patient so much that the fracture is literally extending subgingival.
This is over.
And
presentation I'm attending.
It's extending subgingival, and it's not possible for us to save this tooth. So we had to guide the patient to the right treatment. A lot of patients assume that when you start a treatment, it's all up to us to go ahead and complete the treatment. So that's not the case. We have to educate the patient. We need to make sure that the patient understands the risks involved. For example, this patient had a palato-gingival groove, and we had to explain him quite a lot that the prognosis is moderate. We don't know how it's going to take up. Then only when we showed him a picture of the probe which is going in, and it's going in quite deep, the patient was able to understand. Another patient here, where he had tenderness and percussion with respect to this tooth, 1-4. The root canal looks absolutely fine. The only clinically significant finding we had was at one point he had a pretty deep pocket. At that moment, we didn't know what was going on. We didn't know why he had this pocket. So we told the patient, see, I don't know what's going on. But then as we start the retreatment, we'll be able to give you a better picture. So we removed the GP and we saw the canals. We realized that, there's an additional canal, or was it a perforation? So after taking a few x-rays, and we found that it was probably a perforation. Probably the old clinician tried to do a post-space perforation or something, and he's perforated it. So then we were able to successfully manage the case. So what I'm trying to say here is that we will be able to, not convince, we will be able to share the responsibility with our patients if we are able to communicate well with them. So as a postgraduate or as a clinician, this is quite important. And as a clinician, there are many cases where we start off with something in mind, like an instrument retrieval case, which was referred to us. And incidentally, we find that, there is also a perforation here, which was created previously. So, we cannot do this as charity. We will again have to explain the patient and bill it. So you'll be able to itemize your treatments and charge the patient accordingly if you are able to show them with photographs and your documentation. Right. So another important reason why you want to photograph is when you again start off cases like these, class 2 with proximal caries, you find that the adjacent tooth has a pretty deep cavity as well, and you didn't notice it, and the patient's assuming he's going to get one filling. He's going to be billed for one filling, but then you have to do 2 fillings. Again, these are all something that you can gain patients' trust with. Here's a case where we remove the crown, and then we realize that there's secondary caries underneath the crown, and there's a caries on the adjacent tooth as well. There's no way we can justify these additional treatment procedures unless we show it to them. Sometimes even doctors need to be educated. For example, this was a case which was referred from one of my friends, and he was quite sure that he had filled 2 mesial canals and 1 distal canal, but the patient still had pain and tenderness. So I told him, see, I got another canal. See, he was not ready to believe the radiograph. So we had to show photographs. So photographs is like a vital component in documentation. So what I'm trying to show here is, as faculty, it's our duty to encourage our PG students to take as many photographs as possible, right? So photographs can be divided into two types. One is the standard set and the other is the strategic set. So standard is the basic views, right? In any patient that steps into your operatory or who comes into the clinic, you have to take these views. There's no shortcut there. Strategic is when you want to show something to the audience, when you want to, or to the patient or to the referring doctor, you take appropriate, planned photographs. Okay. So for example, when you talk of, standard photographs we usually take with a good DSLR. So it doesn't have to be a state-of-the-art DSLR. It can be even a simple mobile phone, like Dr. Sajeev was telling yesterday. But I would prefer a professional camera. And the strategic picture or the intra-treatment pictures can be taken using your microscope with the inbuilt cameras. Right. So for standard set, you need 3 shots at least. So this is the guidelines in the UK that you need at least these 3 images. One is the occlusal image, the maxillary occlusal, and the mandibular occlusal. The reason is very simple. There are many things that we miss out. So for in this case, I thought, this patient didn't need anything. It was completely fine. But then in the photograph, I could see a small area where there was a sign of, decalcification and color change under the marginal ridge. So initial class 2 caries. The third picture you need to take is a frontal image where the second molar is also quite clearly visible without being blurred, because you'll be able to, you'll be surprised how many things that you actually missed out during the consultation that you'll find out with a photograph. Right. So there are a few more reasons why we need to take good photographs, strategic and standard. One of the reasons being good treatment planning, right? One is treatment planning for your own, for your own treatment. Second, for communication with other doctors, other specialists like the periodontist, prosthodontist. This is a multidisciplinary case: diastema closure, gingivectomy, right? And also lab communications. If you want to communicate well, you need these things. Photographs also create a huge emotional impact for the patient. When he sees himself in the photograph, like before and after, you can see a huge change in their perspective. So digital smile designing, all of us know what it is. So we all know that there's a standard set of photographs that you need to document when you want to do digital smile design. Right. Now coming to documentation per se, the act of maintaining records. Now, why do you need to keep records? Okay. So most of us need to keep records just to safeguard ourselves. For example, this patient, we did a non-vital bleaching. She underwent ortho treatment, and 6 months later, she came and told us that we didn't do anything. We just charged her for nothing because the tooth was still yellowish. So if we didn't take a good pre-op with a shade guide like this, we would have been in deep trouble. Luckily, we had pictures with shade guide. We were able to show her that you can see there is actually a reference for the shade improvement, and we will go ahead and do another round of bleaching for you. But then we didn't do anything wrong, so we can safeguard ourselves. And litigation in our country is quite uncommon, but it is happening. There are a lot of cases, so it's good to be safe. Also, be careful when there are cases go against your treatment plan. So in this case, I advised her a root canal, but then she didn't want it. So we took extra caution. We told her, see, we'll do a direct pulp capping, but then direct pulp capping working in your situation may not be possible because she already had symptoms of irreversible pulpitis. But then we did it. We recorded the entire procedure. We showed it to her. And a week later, she did come back for the root canal. So it's good to keep records when patients don't take your advice as well. So this happened recently, just in November 2022. A patient came to me, and an old patient of mine, he just showed that he lost the crowns that I did. He said, we did these crowns and it's come out. I in fact thought that was the truth, because that was my first. He was so confident that I did those crowns. So this is the clinical picture. Like you can see, they're just 2 crowns which are come out. The rest of the teeth have their crowns. And luckily, we had our records. And when we went back to our records, this was the pre-op photograph. I'm sorry about the quality. I think this was taken in 2019. It wasn't of great quality that time, 2021, sorry. And we found that we did crowns only for the first molar. The second and third molar already was there. So it was he had already got it done elsewhere. So we were able to show him these photographs. We also had our post-op pics as well. So we were able to show that as well. And, we were able to satisfy his doubt. So, he ended up getting the re-root canal done and the crowns done with us. So easily we saved a lot of embarrassment and a lot of miscommunication, and we were able to continue with this treatment. Another reason we like to document is sometimes, things can go wrong even after cases like these where we complete the instrument retrieval and we give it back to the doctor, and the doctor says, I'll do the obturation, and then he fractures another file and he says, doc, you might not have done it right, So then we have to show him pictures that, see, we have done it, we have removed the file, and it's done properly. So we have to record all sorts of fine details nowadays. So what is the legality part in India? So we all feel that we are not mandated to record the cases. However, according to IDA's recommendation and according to legal sources as well, we found that pre-op records, radiographs, models, and photographs have to be recorded and stored for a minimum amount of time, including the diagnosis and treatment plan that we have planned for the patient. All these have to be meticulously recorded and stored for at least 8 years. Okay. Models, however, I'm not saving them. I save maximum for about 3 months, and then we discard them. We don't have the space for it in our clinic. Our clinics are quite small, but if you have a dedicated records room, maybe you can save the models as well. And treatment progress records, again, very important. Every time a patient steps into your clinic, you have to record it with the date and the time. So these are not my recommendations. These are what you're legally bound to do. Okay, so that's a legal part of recording. Second, the next reason why we record is, communication of shade, right? Just like how Girija ma'am was telling the importance of a good cast post. I believe my cast posts were very good during my PG, but then my lab guys used to screw up the crowns. I used to get horrible shade matches, and we had to repeat them several times. So it's one of the main reasons why you waste time and stuff. So most of us believe that single anterior crowns come only with luck, but with proper discipline in documentation and photography, we will be able to negate this, because we feel that our technicians don't understand what A2 is, but then he knows what A2 is. But then there are so many other factors in the tooth shade which we are not communicating with him, because all that poor fellow sees is this. We say A2, it could be a young guy, it could be an old guy, he could have so many things. So we take shade pictures using at least 2 or 3 tabs, and we give a high contrast, and we give a high value, or basically a monochrome image. The monochrome image communicates the value, the high contrast communicates the shade map, and then the normal is for the basic shade matching, right? So this case had and fly. This was actually he was a French patient. He had to fly back after a week. We didn't have any leeway space for any changes, so we had to get it right. Luckily, we got it right thanks to the shade communication. There's another tool when you want to document the shade without reflections or shadows. So that's called polarization. Cross polarization removes the reflections from gums, the tooth. You'll be able to see the incisal halo and everything more clearly. Quite an interesting tool. A tool that really objectivizes and changes your shade game is using lab values. Okay, so when you put these monochrome images in Photoshop, you actually get the value of the tooth, and you can match it to the shade tab and tell the lab guy the exact shade tab, and you can eliminate reworks. Another reason is we like to communicate with the lab with annotation, especially if it's like dent care where they don't understand your language. You have to show what's wrong with the crown, and then you can annotate and get the work done. So we all love to see how our work has progressed over a period of time. So follow-ups are very important. Follow-ups make you a better clinician. Don't just see the good ones. So I used to have this bias of ignoring my mistakes and just seeing what went right all the time. Well, I started seeing my mistakes, and it helped me learn a lot. This was a onlay. This was an inlay that I made, and it failed within 3 months. And then we ended up doing a composite. Sorry, I missed the animation there. But then we learned a lot from this case, and I have the photographs of the exact inlay design that I use, and I realized that I should never do that again, right? So introspect your own work with documentation. So when you want to educate people in forums, for example, this was one of the videos that I created to show the importance of microscope in root canals apart from access preparation, because most of the people feel that microscope is needed only for access preparation. You don't need for anything else. But microscope helps you in several steps during the root canal. So I took some strategic photos and videos just to show the importance of microscope during the basic endo work. So these are important things that postgraduates have to do. During my PG days, we were pushed to record our own photographs, and we were not allowed to use Google Photos. So that again, helped us document our cases with strategic photographs like this. And in today's world, with the competition around, you need to ensure that you make a niche for yourself. You need to build your own portfolios, show to your patients, show to your colleagues, make clinical albums. Like Dr. Rajkumar sir was telling me that day that most of his PG students get a job because of the clinical album. That's true. Same case here. I got my job in Ambedkar predominantly because of this. My case album was good. It works. Whenever I get bored, I also make an interim case album every year, just to see where I'm standing and just to show my patients. And when you want to present in whenever you want to present in international forums, documentation is very important. And when you want to publish it in good journals, again, you need good quality photographs and properly documented cases. In fact, there are many journals which ask for particular type of image like TIFF or JPEGs of higher quality. The final reason why I would like to document is final, but probably the most important, is for your professional accreditation programs like the Royal College of Surgeon programs like the Endo, or even MFDS doesn't require it. Endo needs case presentations. IACDE needs case presentations. So documentation, you just can't live without it. In fact, when I was preparing for Endo, this was my exact folder which I made during my PG days. And these are all the case photos that we all make, right? So I thought I was very organized. I thought everything is according to the treatment, and I can get whatever I want whenever I want. But then when I opened each of them, I realized that none of them were complete, at least to international standards. So it was very disappointing. So I'm going to show you techniques now on how to document it well. So the next half of my presentation is going to be that way. The final reason why I document is because we are trying to build a referral relationship with a lot of doctors, and then we find that most of them are hesitant to send a case to another doctor because they don't have really a clue what happens to the patient when they come here, or after they send back what exactly happened. The communication and the clarity is missing. So again, documentation goes a long way in helping us achieve this, right? So just to summarize what I thought, I hope all of us are on the same page. We all believe that documentation is very important, and it's our duty to drill this again into our students' heads that it is quite important. So I know I don't have to talk so much about why it was important, but I feel if we understand why something is important, we will find ways to do it right. We will make our own ways. You don't need a set guideline why to do it. Okay, so the next half of my presentation is going to be how to document. So we, in my clinical practice, initial days, we didn't have so many staff. I used to do almost everything, but then now it is a completely team game. It's without my team, I just can't document, right? It's as simple as that. I'll just tell you how my team members are involved in documentation, and this can be correlated with your scenario. If it's a college, you can ask the receptionist who's in your department to send the registration form. Maybe you don't have a registration form concept in your department, but you can bring that up, and those things can bring about a change, and it can save a lot of time. So my front desk will give a registration form. They fill it up, and then the demographics from the registration form is entered into the practice management software by my front desk, and my associate doctors double check it, and then they make sure the vital information like medical history and all is entered properly. And then my associate doctors usually take the first they do the first set of round of consultation. They take a regular set of photographs and x-rays, and then we go in, we do a detailed clinical examination under the microscope and dictate the findings to either the associate doctor or my receptionist, whoever is available. They write it down, and we take some special photographs which we feel is necessary at that moment. And then we ask once the consultation appointment is over, we make sure that the patient folder is created by, only the doctors used to do it, but then now we've trained our assistants also to do it. So they're also able to do it. So your chair assistants in your department can be trained. So basically you need to train them. They can do it. And after that, once the folder is created, we upload it in the practice management software, and then we can share it with the doctors or the patients or your staff. So let's see how this is done in detail. So first, the registration form. We used to have the paper records. Almost the first 600, 700 patients we did this. We found it was very cumbersome to go back and look into the stuff and get to type down entire thing again. So we moved to electronic records. It's easier to copy paste into the practice management software. It makes the whole deal very easier. However, we still have paper only for consent form, and then we use some paper for writing down notes. Consent is very important. We take consent for all our patients and we upload it in the software as well. However, electronic records are not perfect. There are a lot of downsides there as well. One of the main thing is if your employee just knows the password, or if someone who doesn't like you knows the password, they can literally spoil your happiness. They can, in fact, the reason why I'm putting this as first point is because it happened to us in our clinic. One of the employees who left us, they deleted a lot of patient records when they left. So be careful with who you give the access to. Computer training is essential. We do a basic computer training for all the people who join us. There is an expense involved. There is a yearly fee for all the softwares that you use, and backups, right? So we use a lot of hard drives right now. There's hard drives lying around everywhere in my table. Be very careful that you don't lose these soft copies. It's very expensive to recover them if you don't have a backup. Right. So where do you think the patient should start with the registration form? Do you think a patient should sit and fill the registration form when he's waiting for your appointment, or do you think it should be earlier? So we feel it should be even before he steps into your clinic. It should be right at the time when he books an appointment with you. You send a WhatsApp message to him with the registration form, and he should be able to at least fill the demographic details. So in the demographic details, okay, there's a couple of things I wanted to tell you. One is don't record the year of birth. Instead, ask for the date of birth, and always ask for a WhatsApp number, because most of the patients have 2 numbers, and ask for a WhatsApp number so that you have better communication. You don't lose out on that patient. Very important thing, how did the patient find you? This is, if you want to build your marketing strategy, this is once you move out of your college and go into practice, it's very important. And also you need to know if it's from a referral doctor, because if it's from a referral doctor, you have the responsibility to send that patient back, and you have to be in constant touch with that doctor, right? And we need to know from where which doctor, which clinic, and what procedure, and etc. And occupation, we all know why. Medical history, very important. Put all sorts of stuff, because sometimes patients forget to answer, and they may not know the exact terminology. So give a drop down or a pop-up list, which will be easy for them to handle. And medical history is very important for medical legal cases as well. Dental history, we all know why it's important. There are a few additional points which I would like to mention. One is always ask this question: in the previous dental treatment, did you undergo any trouble? So you'll know whether he had any medical complication or a dental complication during a previous thing, or was he unhappy with the entire process, so that you can give him a better experience. And also ask them, what was your health? What is your perception of your oral health? Because that will give you an idea of how much that person values and has awareness of his dental health. A weird thing to ask in a registration form is the chief complaint and the pain history. In fact, we ask questions right down to where you're feeling pain, and what are the relieving factors and aggravating factors, and how long does the pain last. You might feel it's not important, but then we feel that it's better to have a relatively rough idea of what the patient is undergoing before he comes to you, because sometimes it could be an emergency. You don't want him to make him wait, or sometimes you can keep your armamentarium ready even before the patient comes, right? So once he fills the registration form, you should be able to get a spreadsheet like this with the patient's age, his contact details, his phone number, everything, his medical history, his allergy history, and dental history, right? So when I just scroll through this Excel sheet, it gives me a pretty fair idea of who I'm going to deal with and how I should talk to him, right? And it also gives my assistants and doctors enough time for them to add it in the practice management software, so that we don't miss out any vital details. Okay. Coming to the practice management software options. So we're talking about digital dentistry nowadays. Most of the practices don't use papers nowadays. So so a lot of practice management softwares have mushroomed up, and we find that more or less they're all the same. They have similar concepts. You won't go wrong with anything. Just make sure that whichever software you're using allows photo storage. Okay, unlimited photo storage, because the photos that we take are big. The photo that comes out of my DSLR is at least 5 MB, and I put at least 20-30 photos for every patient. So it's a lot of storage. Next thing you need to look out for is whether these records can be shared to the patient directly without me having to mail the patient. So there is an option in the software that I'm using. It's called Practo. It's there in many other softwares as well. I think Bestosys, Papijo, many of them have the same thing. Right, and make sure the software is customizable. So that's one thing that this software doesn't have, Practo. So, but a lot of softwares have customizable options. I think the software that they use in Savita is excellent. The gold standard software is the Digital Office by Dr. Gary Carr. It's a dedicated endo practice management software. Someday I would like to own it, but as of now, I don't know. I don't have it, and I don't know how it really works. But then I went through the entire software. It's fabulous. You can put exact, it's very intuitive. It helps you record each and everything, right from in each canal. What sealer did you use? What working length did you use? What exactly happened in the canal? Did you get a ledge at the 14th millimeter and you were able to negotiated. So all those details go into this software, right? And all these details fantastically comes out as a report with just a click of a button. So excellent software. If anyone wants, can go ahead and purchase it. But what we use is Practo. So we use Practo is very simple, straightforward. Just that you need a helping hand. You as a doctor yourself may not have the time to sit and enter everything. So you need a team or a hand to do all this. So my front desk would have entered all the demographic details, especially if it's a referred case, you have to enter all that. And the medical history. Medical history, extremely important. And a good thing about the software is that the medical history keeps popping up as a notification whenever the patient steps into your clinic. So once the patient comes into your clinic, the first standard photography workup is done with either my associate doctor or my assistants, and they take the 3 sets of photographs and they put it in a folder, and it's ready for me to come and examine the patient. So I examine the patient, take some strategic photographs, and then we discuss with the patient what are the current findings, and we after which I give a detailed note for each tooth, we basically a clinical examination and detailed radiographic intraoral examination, etc. Sometimes we might miss out on certain parameters which we should have looked out during our diagnostic. So we have a template which we just keep it chairside. We don't mark on it, but then we just go through it to make sure we don't lose out on any vital information. So a template is always good whenever you're looking at a new patient. So it's good to have an associate doctor. What I mean by strategic photographs is, for example, this case had a perforation when we just opened the access. So this I couldn't have shown the patient unless I myself, took the time and under the microscope examined and showed the perforation with greater detail, right? So always use a combination of 2 documentation modalities. Use either your DSLR or mobile phone, and then also use your microscope to take the strategic photos. So after we take the photos, we take the memory card, put it in the computer, and then we document it into a patient's folder, right? So this folder contains literally everything that we have done till now. Alphabetically, all our patients are arranged with the OP number so that it's easy for us to search. Lots of data there. So under each folder, you will find an pre-op, a post-op, an intra-op picture, all the strategy photos, a review, CBCT if it's there. So all these photos, if they're not put into the folder, into the patient within 24 hours, trust me, errors will happen. So documentation is a discipline, and it has to happen every day at the same time. And your doctors or your assistants have to be trained, or you should be trained to do this, because we forget what we did yesterday. It's as simple as that. Because for a simple example that happened in my clinic is when we had our year-end vacation, my doctors also took it a little chill, and the 24 hours became 72 hours, and almost half the case records were all jumbled up. So make sure everything is done on time. Another important thing you need to make sure that happens is the consent form that you take from the patient also has to be entered into the practice management. Just take a picture or scan it and put it in the practice management. Even the treatment details, the treatment plan that you gave, it has to be in the consent form. It has to be in the practice management software. Every 1 week, we make it a habit to export the photos, the X-rays, and put it in the folder and make sure that it's backed up. We literally have, this is just a small bunch, we have around 5 hard drives and totally around 10 or 12 TB of data right now. So that's a lot of data. We can do an online cloud storage as well, but it's a matter of personal choice. I like physical on hard drive storage. So, but whatever it is, please back up. For personal use, use flash drives like SSD drives. For other sort of, for regular clinic backups, your regular external hard drives should be quite sufficient. Okay, so the next question is, Praveen, if you record all the cases just with their names, how do you know what you did? And if at all you want to see them in the future, like for example, I'm preparing a presentation on instrument retrieval. Which are the patients I did instrument retrieval on? I'll forget after a month, right? So we do something called indexing. Every patient that I do a special treatment, or if I feel done, I've recorded something, I index them, like instrument retrieval, pulp capping, pulp stone management, apexification, contact tightening, veneer, spit and freeze. Basically stuff that we do routinely as an endodontist, but it's organized in one simple Excel sheet so that we can use it when we need it. The next set of data that we need to record is treatment progress. It's very important that you record it as and when it happens, because the amount of hypo you used or what irrigation system you used, you will forget it probably after a day, right? So it has to, you have to keep dictating it. This happens, offhand with a rough note that my assistants have at the chair side. They always have a rough note. They use this, they use a pen and paper, and then they write down as I dictate, right? Sometimes they, after the case, they'll be like, sir, you told me something, I didn't get it right, the spelling is wrong, so I correct them. So this exercise has to happen so that you know what you did during the treatment. Again, this also can be template guided, although we don't use a template for this very often. I usually just do it based on the significant thing, but working length, the obturation size, the sealer used, the type of entrance filling given, all these things, and then that rubber dam clamp that I used, everything will be recorded. That goes without me even thinking. So it's like I'm used to it. Okay, and when you want, after you've completed all the documentation, the next step is to send this report either to the patient or the referring doctor. Most of these softwares that you use will have a built-in feature. If you see, there'll be a print icon there. If you click on that, you will find that the data comes in, although not very organized. I don't recommend Practo for this. I don't know about the other softwares. It's not very organized, but then the data is there, and it takes some time for the reader to understand what's going on. The built-in feature is okay for this. The built-in feature also helps, can attach all the photographs that you've uploaded in Practo, and they make it a sequence of files which are attached in the same PDF document. Well, it's okay. I can send this to a doctor. An intelligent doctor might understand it. But then if you are in the mood for presenting it well to the doctor, and if you feel it has to be concise and very well written, then you need to use a simple word template. I can share this template with you. So we have this template where we send it to almost all our referral doctors. We put the patient's name, our clinic logo, and then the referral doctor's name and stuff. So since it's already a template, it's very easy for us to so to just add in the details. We just copy paste from the practice management software to the Word document, and then we put the photos and we do. So this exercise should not take more than 15 minutes. So again, these are tasks that I assign to my associate doctors. Okay, a decent way to present your cases. After which we usually mail the entire Word document and few other photos, and we give a very nice mail. We thank them. First of all, we call them and say that your patient came, we finished, we are sending these records, we've documented all this, and then we give a nice mail to them so that we are on a good rapport, right? So I think I've given the gist of my way of documentation in our practice. I feel this is something that even PGs in every college can incorporate with little bit of changes here and there. So I hope this lecture was useful. We have a page on Facebook. It's called MicroSmile, where we keep adding a lot of tutorials on endo and documentation. We have a page for photography as well. It's called DIY Dental Photography. So if any of your students want to see it, they can go. Also, we've been training students for the Royal Dream, and we have a nice page to educate students on the basic doubts that they have regarding M-Endo and M-Moth. It's on Insta. It's called Prav Endo. So I would like to dedicate this talk to my grandmother, who is a very what do you say? She's a very giving lady. She shares whatever she gets, and I feel I've got that. At least I try to do that in my lectures. I try to teach everything that I know to the people. I'm sorry if it was a pretty long lecture where I bored you all, but I just wanted to give everything that I knew about documentation. So I hope it was useful. Thank you all for this wonderful opportunity, Mahalakshmi ma'am and Rajkumar sir. Thank you.
Thank you, Dr. Rajesh. Wow.
Thank you.
It was such a wonderful lecture. I mean, from the lecture itself, take out that, I mean, your in-depth knowledge about documentation and then your enthusiasm about it was really clear out. And that really kept us engaged. You are telling us that you bored us not at all. I didn't even realize that it was going to come to an end. I was like, it should go on. It was so very wonderful work. And then I think it has definitely motivated us to go in for more of documentation. And then I think after I've seen you doing so much of thing, we'll be more comfortable putting up all this. Till now, we were also thinking like, no, so much of documentation is difficult to handle. But after seeing your work, I think it's not that difficult. It's just getting into the habit of it. And
yes, ma'am. It's all about creating systems. Yeah. I think even in PG, if we create a habit and a system, of course, you can't do it single-handedly. It's difficult. You need at least one extra hand, but it can be done.
My complete appreciation to the women power in your team that I saw.
Oh, yeah.
I mean,
exactly. I also wanted to comment on that.
Wow.
Yeah.
Wow. I really want to appreciate that. Very well.
Thank you. Thank you. In fact, in Google, when we put these pictures in Google My Business page, it automatically said, this is a woman-owned business. I was like, yeah, okay. How did you know about it? Okay. But yes, it is. In fact, the entire management of our practice and everything is my wife only. Kritika takes care of everything. I'm kind of like a consultant who just handles photography, documentation, and all these small things.
Definitely. I mean, I appreciate the work that they're doing. And you've updated us on so many things, especially the record keeping for 8 years. For me, it was like we have to keep it for 5 years. But from you, I've come to know that 8 years. So that's really nice.
Yes, ma'am.
Updating us. And then I mean, magnification has become an integral part of successful endodontics now. No longer I can say option. No, it is not an option now. We want to practice successful endodontics. Definitely, we need magnification and then intraoral. And that was a new thing that our co-endodontists can also put up a blame on us, saying that you've not removed the instrument. It is not done. I never thought
that was a crazy experience for me as well. So
not at all expected. I mean, patients doing all this, but the fellows doing all this was not expected.
Sad part is most of the referral doctors, they'll be like, doctor, reduce the charges of the referral and all. We'll be like, okay, then you do the operation. I mean, we say we'll complete the root canal, but then they'll be like, please reduce the charges. Then okay, fine. We say, okay, we'll do the instrument removal, you continue the RCT. And those things are a little dangerous. I don't think we should be doing that. We should complete the root canal and send.
And then thank you for telling that one of your teacher told that MDS Endo is not as important as other things are. I mean, that was also updating all teachers that we need to stress more on why MDS Endo is more important than anything else. Though my place, MDS Endo is the first branch that they choose. So that way it is doing very well. But then I never knew that all this is also going on. So I've been updated on.
No, because a few of my students have asked me, sir, why should I do MBS? Anyway, after that also you're opening a general practice. I'll do 2-3 courses and I'll open a general practice. Why should I do this? My own MBS batchmates, like I told you, two of them did implant course, and they are practicing implants, right? So
yeah.
So we have to make endodontics as a standalone.
Can I put in here, because in India
Yes,
we still do general practice, everybody.
yes, ma'am.
Very few, I mean, we can even count on our fingers who do specialist practice. Everybody doesn't. And as a general dentist, when you're allowing a BDS graduate to open a clinic, he should know basic endo. My take is that endo, they should know the level of difficulty in each case. Simple cases they can definitely do. We teach them endo in the undergraduate level. So we can't expect them not to do a simple anterior or a single rooted tooth, and they should know where they can, even a calcified canals and totally calcified upper anterior, they have to call a specialist.
Yes.
So you have to do it under microscope. And there are, I know many BDS graduates who do everything under microscope, and they do much more beautiful endo than us.
Yes,
so this does not definitely depend upon, the being a specialist. So as a specialist, you should respect your own specialty, and you need to do a specialist work for yourself to be considered as an MDS, right? So that way, I think, anyway, thank you so much for that wonderful lecture, Praveen.
Thank you, ma'am. Thank you so much.
It was really very useful, mainly for the faculty members who can now motivate the students to take pictures and document. As you said, in MDS, like if we ask the students, most of them have folders like how you had, but then pre-op, if the pre-op is there, the working length is missing. If everything is there, the pre-op is missing. So all this really matters. And Kamal, for your lovely moderation. Thank you so much.
Ma'am, I need a permission from you and Dr. Rajesh.
Yes, please.
Yeah.
Ma'am, I share this lecture not share this lecture, just let my PGs listen to this lecture, so that, because